Welcome, everyone. We're glad to see you here today. We want to welcome you all to today's webinar, the Schwartz Center Innovations in Caring for Vulnerable Populations, the 2024 Corman IMPACT Honor recipients. Thank you for joining us. I'm Julie Collier, Senior Director of Programs here at the Schwartz Center. As many of you know, we are a Boston-based nonprofit organization established in 1995 to advance compassion in healthcare. Our vision at the Schwartz Center is that everyone who provides and receives healthcare experiences compassion. Before we begin, I'd like to share a few details about what you can expect. Please note that the program will last 60 minutes with a panel discussion for the first 40 minutes or so, followed by some time for questions. Feel free to enter your questions in the Q&A pane throughout the discussion. I'd also like to acknowledge with gratitude that this Compassion in Action webinar series has been funded in part by a generous donation made in memory of Julian and Eunice Cohen and by our national business members. With that, I'll hand it over to Dr. Beth Lown, Associate Professor of Medicine at Harvard Medical School and Chief Medical Officer of the Schwartz Center for Compassionate Healthcare. And I know she's excited to get this conversation started.
Thank you, Julie, and thank you everyone for joining us. Today, we're gathering to celebrate the 2024 Corman IMPACT Honors recipients and to learn about their innovative programs that provide compassionate care to vulnerable populations and create safe spaces for patients and their care teams alike. This year's recipients are the Jefferson Addiction Multidisciplinary Service serving the Philadelphia area, which improves healthcare for people with substance use disorders and the people who care for them. And they are represented by Aidan Rogers and Phil Durney. And also the Children's Minnesota Gender Health Program serving Children Minnesota Health System. This is a multidisciplinary and comprehensive program that partners with transgender and gender diverse youth and their families. And that effort is represented by Dr. Kate Gepfert. So thank you all for being here and congratulations for winning this wonderful, wonderful and well-deserved honor. I'd like to begin by asking each team to just briefly describe what is your program, what it's all about, why is it needed, who's it for? So Aidan, do you want to kick us off?
Absolutely, yes. So our service is called the Jefferson Addiction Multidisciplinary Service. We are here located in Center City, Philadelphia, serving patients with substance use disorders of all kind, but certainly a particular focus on patients with opioid use disorder, given the massive amounts of substance use or opioid use that is in Philadelphia. That's who the service is for. We started in sort of early 2021 in the wake of the pandemic. Withdrawal and addiction was getting harder to treat given the increased amounts of substance use and homelessness in the city. Adulterants in the substance use or in the fentanyl and heroin supply were getting more and more complicated, with tranq and or xylazine being found in fentanyl supplies. So it was getting harder and harder for doctors in the hospital to sort of serve our patients just as generalists, needing really specialized care for addiction, as well as with in bolstering our social support for our patients, because we were finding that without very selective social work and certified recovery specialist treatment, patients are just going to bounce back in the hospital without proper aftercare planning and support. So for all those reasons, both on the medical side and the social side, our team has been serving patients since about 2021, more formally since 2022. And it's grown from here, and it's amazing to be honored.
Wow, it's our pleasure to have you. Thanks, Aidan. Kate, how about you? Can you describe your program a little bit and who benefits? Why did you start it?
Yeah, absolutely. First, thanks for the honor and for having me. We're really grateful to the Schwartz Center for highlighting our program and the care that we provide to trans youth and their families. So the Children's Minnesota Gender Health Program was launched in 2019. We're, as you mentioned, a multidisciplinary program that supports the health and well-being of transgender and gender diverse young people, along with their parents and families. So we're a team that consists of medical providers with specialization in pediatrics, adolescent health, and endocrinology. We also have mental health providers, including child psychology and licensed clinical social workers. We have an interdisciplinary team that includes nursing and social work. We also have speech therapists, psychiatrists who help us with medication management. So really a good wraparound of services for each young person that we care for. We see all transgender and gender diverse young people up until age 18 for new patients. We see slightly older than that for patients that we're already caring for. And really our role is to kind of meet the unique needs of each patient that comes through our doors. Most of what we provide is resources, support, connecting with community resources and support, helping families navigate schools and extended family and social transition for their young people if that's what they desire. And then in some cases, letting them know what their options are in terms of medication management and treatment as adolescents get older. We're in the Twin Cities in Minneapolis. We definitely serve people here in the Twin Cities metro area. We serve the entire state of Minnesota. And from the get-go, really, we're serving people in surrounding states. Why this program was so needed is that providing specialized healthcare for trans and gender diverse young people is something that just wasn't really being done in this region, specifically with pediatric experts before our clinic opened. There was a lot of young people trying to get services at adult care centers, which caring for teenagers and children is very different. This is a group of young people who are really targeted. They're targeted in their schools. They're targeted sometimes in their own families and certainly in their communities. And so they experience disparate health outcomes, particularly with regard to their mental health. And so providing good care and support for them is really important. So why we launched was to help trans and gender diverse kids thrive and really make sure that they could access the essential healthcare they need. Within months of launching, our wait list was long, and we've had consistently a year-long wait list since we opened. And then, of course, starting in 2023, there was a political agenda to ban essential healthcare for trans and gender diverse youth. So at this point, why our program is needed is that in 25 states, access to gender affirming healthcare for youth is either restricted or banned in those states. And so we're now serving a much bigger catchment area. We sit as an island among states that currently have bans in place. So we're serving young people and their families who are both traveling to Minnesota for that care, as well as moving to Minnesota and relocating their families to get that care. So we've expanded our services, which I know we'll talk about later, and despite that, cannot keep up with the demand because there are more and more young people who are coming to our doors seeking advice and support and resources. So a lot more work to do, and we're hoping to help meet the need as we can.
Yeah, thank you. The work is endless for both of you, and that's the sadness and I guess the uplift, that people are coming to you and seeking your support and your help and guidance. So thank you all. Let's talk a little bit about implementation of these programs. What did you do? How'd you go about this? What were some of the challenges? We've already heard a lot of the challenges, but Phil, why don't you take this one?
So to build off a little bit of what Aiden already mentioned, back during the pandemic, we saw an uptick in medical complications of patients that were coming to the hospital with substance use disorder. And before that time, there wasn't really a very comprehensive model that we had in our system. These patients would come in through the emergency department with really severe infections. We saw really severe wounds as well because of the adulterants in the drug supply, specifically xylazine, which was becoming more pervasive. And a core group of our faculty got together between emergency medicine, internal medicine, family and community medicine, and the Department of Psychiatry. And we realized that we were kind of taking more of a piecemeal approach, and we were practicing in silos, and we wanted to come up with a more comprehensive model and build really an ecosystem. Like Aiden mentioned, there's not just medical recommendations to stabilize these patients in the hospital, they also need a lot of support, and they can't be treated as just, one-off cases. So the stars really aligned at that point. We had a lot of departmental conversations, and we started to build the team. We also received an extremely generous donation, a philanthropic donation, from Stephen and Sandy Scheller, which is what our program is named after, the Consult Bridge program, and the Consult program, and then the Outpatient Bridge program, which is our outpatient counterpart in clinic. So we definitely faced a lot of challenges when we started. We were one of the first co-management services at Jefferson, which basically means we don't just see the patients in the hospital and offer as a consultant team medical recommendations. We actually follow them almost every single day of their hospitalization. And we are a multidisciplinary team. So we have our own pharmacists, we have our own specialized social workers, we have our own recovery specialists. And we have really created a model that's very akin to transplant medicine. So it's extremely multidisciplinary. It's very supportive. A lot of our patients face a lot of challenges in the hospital, from a stigmatization standpoint. So our team is not just providing, medical recommendations to treat withdrawal, we're also providing support for the patient as well as support for the care team, support for the bedside nurses, the case managers, the other social workers, to try to bridge some of these gaps that we see, which can really make or break treating the acute complications, and the patient remaining in the hospital. And the last kind of challenge that I'll mention, I think when JAMS really started was, I think part of the magic of what makes our program so great and work, it was also a challenge, I think, initially at the beginning. And what I mean by that is we had faculty that are trained differently, coming from different specialties. So I'm, internal medicine trained, working as a hospitalist. I don't have the same scope as a psychiatrist who's seeing patients in the hospital. So initially when JAM started, it was a consult team that fell under the Department of Psychiatry. And as we were working together and the program began to grow, we had to develop, a clear scope of what patients we would see in the hospital and how we would treat them, and try to keep that scope consistent depending on who was staffing the service. If it was being staffed by a psychiatrist one week, and then the following week it was being staffed by a family medicine or internal medicine physician. But I think that that's what makes our program so great now, because we have a core group of faculty that are coming from different backgrounds, and there's a lot of concomitant, psychiatric diagnoses with patients that have substance use. So we're able to bounce ideas off of each other and provide, a more comprehensive treatment plan for our patients.
Thanks, Bill. And I think also, linking the acute inpatient experience to the Bridge program is absolutely critical. I know, some hospitals have started that, not all. And I think without it, it's, people are really at high risk for relapse and additional complications and readmission and, this endless cycle of suffering.
Yeah, we brought a lot. The Bridge program is extraordinary. I mean, we brought so many resources into the hospital because these patients view, the hospitalization as a touch point or kind of a doorway into access to these programs. And a lot of them are combating, housing instability, transportation issues, food insecurity. There's a lot of social determinants of health. So this is our program has really served as kind of a funnel to offer just an array of services to patients while they're here, and kind of connect them and get them plugged in to community resources.
Fantastic. Okay, can you talk a little bit about your sort of, your pathway implementing your program? I can't imagine it was easy. You had to get a lot of support and buy-in to address this because, these are vulnerable and also stigmatized populations. So why don't you talk a little bit about how you went about that?
Yeah. So first, I think it's important to point out that the year in which we were conceiving of and implementing this program, we launched in 2019. And so really a lot of the work putting into that happened in 2018. And that's really important because that was a really different time politically than it is now in 2024. And so the good news is that at the time, knowing that this is something that our community needed and that our kids needed, there were already probably, a dozen or so programs across the country at children's hospitals that were providing care to trans and gender diverse young people. And so I had the opportunity to go to places like Seattle Children's and like Lurie and like Cincinnati Children's and Boston Children's to learn about how they had put together their programs, understand their model of care and, the different team members that they were utilizing, and try to figure out how we could adapt that to our setting and to our patients at Children's Minnesota. And so, kind of putting that all together, we were able to start. We started pretty small. There were 3 of us providing medical care on a very part-time basis and 1 clinical social worker, and that was kind of the team. And so we built as we grew. And I think, one of the challenges early on was just meeting the needs of the community. And we, started small. I told the operating team when we put together our pro forma to launch this program that we would see 90 new patients in the first year, and we ended up seeing over 200. So one of our biggest challenges has just been keeping up with the access and the demand, and we've been able to grow to keep up with that to some extent, but not entirely. So making sure that patients have access to the care that they need, and the thing that keeps me up at night is the patients on our waiting list, and just knowing that they're waiting to get help and resources. The other thing that was really important during implementation was to understand the care model that we were committed to and then committing to it. So the WPAS Standards of Care, which is the World Professional Association of Transgender Health, they have standards of care that came out in 2022 that refer to adolescent patients and really talk about a interdisciplinary approach that incorporates mental health into the medical care. And that was really important to us, not only because it's the standard of care, but also because that felt like the right way to provide care for a population that is so stigmatized and experiences disproportionate mental health outcomes. The challenge is that we are in a state of pediatric mental health crisis right now in this country. And so there just are not enough people to provide pediatric mental health care. And so trying to put together the resources that we had at our hospital paired with the resources that were in the community, and trying to combine those to make sure that our patients and families were getting the mental health care and ongoing therapy and support that they needed was certainly a challenge for us. And then, as you alluded to, there was some at the beginning, certainly more as the program has gone on, but just myths and misconceptions about the care that we're providing and how we're supporting kids and families. I think we had the benefit in 2019 of not a lot of media noise about transgender kids or transgender healthcare. And so we were really able to, with our board of directors and with our executive leadership team, give some really accurate factual information, get buy-in around why this care was life-saving and so important. Provide factual evidence-based studies to them, show them good mental health outcomes, so we could get the program launched. And, since then, really in the last 2 years, we've had to do a lot of kind of going back and relaying that foundation, doing a lot of myth busting around things that have come out in the popular media, and making sure that people understand that this is slow, methodical care, that it is provided by a mental health and medical care team, that we are following guidelines, that it's age appropriate, that no, we are not doing surgery on children. And, all of these things that we actually didn't have to do when we were implementing the program. And now we've kind of had to go back and do that, years in because of the changing political environment.
There's just a constant re-education, and countering the mis and disinformation systems and, information that's out there. It's just so challenging. Yeah. And also the shortages of mental health providers just is so rate limiting, It's really a very difficult situation. I think I'd like to hear about, all of this is making me feel anxious and stressed. It's inspiring, but it's also, it's hard to sort of guess I'm resonating with some of the stress that you must experience. I understand the joys too and the rewards of taking care of these patients that you're so devoted and committed to. But certainly there's a lot of stress. And I have to say, in terms of the JAMS service, the addiction service, I had been unaware of the severity of the wounds that are caused by this adulterant, the xylazine. Just had no understanding of how significant that was, how incredibly painful those wounds are, how that sets people up for relapse because they're trying to deal with their pain. It's just so incredibly complicated. So I would love to hear how you have coped with all of this, and how you've managed either individually or as a team. So Aidan, let me start off by asking you to address that.
Yeah, that's a great question, and your remarks about how it would kind of make you anxious as a provider, I think, is one thing I want to touch on, because the existence of our team almost acknowledges that this is a difficult population to work with, right? We've heard so much from our fellow providers and my fellow social workers that they're just so relieved that we're available as a consult service. It's a very complicated system. So I talk with my other social work colleagues about how, it's hard to remember what rehabs take what, and the insurance systems and private insurance and all this stuff. So it's really great to be the team that is kind of providing that relief. So just to comment a bit on, stress management at the hospital level.
Yeah.
But more within our team, I would say the biggest thing is communication. We're able to sort of filter out like what patients go to who, right? Not every patient needs to be seen by a doctor. Some are patients just for me to engage with therapeutically, or some patients are too medically sick for me to see. And, their wounds might be so severe that they're not really ready to talk with a social worker, right? So we're not really having to take on the burden of the entire population of patients with substance use disorders in the hospital. We're able to kind of filter through and kind of take care of ourselves in that way. Certain practices like end of the week check-ins are very helpful for us, as well as just getting feedback from one another. Dr. Durney mentioned how it can be helpful for, the doctors to bounce ideas off one another, and once again, not feel like alone, even though you are supposed to be the expert, as the JAMS attending. There's other providers that that have your back and you're able to, consult with. And at the same time, it just offers different perspectives. Last week, I was talking to my colleague, Susanna, who's our other social worker. And I was talking about kind of feeling very overburdened by patients that are so quickly bouncing back to the hospital, and how discouraging that is. And I think she gave me really good feedback as far as like, it's more of an opportunity to get to know the patient better and adapt, instead of feeling like our previous treatment we provided was a failure.
Yeah.
So all those reasons, I'm just so grateful that our team makes it a goal to support each other. And then I think that one of our missions is to support the hospital and the hospital staff at large.
Yeah.
So I guess that's what I'd say.
Yeah, no, that's really helpful. Yeah, it's sort of stress first aid for each other,
Right.
Yeah. Thanks, Aidan. Kate, what about you and your team? How do you manage? What helps you?
I mean, I would just really echo a lot of what Aidan said. I think the fact that we are a team, and that we do work together to care for patients is really, really helpful. So, patients are not just seen by one of us, they're seen by multiple of us, so at least two of us, a mental health and a medical provider, and often our nurses involved and our clinical case coordinator. And so, when there are challenges that come up with individual patients, or when we experience challenges as a program, or, negative messaging from the media or the community or otherwise, I think having each other is really, really important. I think that's what sustained us through some of the harder times, whether they're harder patient situations that we've had, or like I said, other situations that have come up. We're taking care of a population that is known to have, as I said, sort of disparate mental health outcomes, and known to have higher rates of suicidality. And the first time that we lost one of our patients to suicide, that was devastating for our entire clinic, not just for the one or two folks who had direct contact with that patient, but really for all of us. And so I think we couldn't do the work without each other. And then, the other thing that I really think helps sustain us, and I have to give kudos to Children's Minnesota for this, is the support of our hospital and health system. essential healthcare for trans and gender diverse young people has come under such political attack that has extended to us as well. The hospital has gotten threats and gotten anonymous calls from people. I personally, due to my visibility both at the legislature and doing advocacy around some of the laws we've passed here in Minnesota, but also media interviews and other things that I've done, have had personal threats against me and my safety. And I've never once felt unsupported by our health system. Our security team is locked in and knows, when things are flaring up and when they need to be there for us. Our marketing and communications team is all over what's happening on social media and keeps us abreast of what's going on. And our executive leadership team, our CEO, and our entire executive leadership team, and including our board of directors for our hospital system as a nonprofit hospital, have stood behind us and with us 100%. And that makes all the difference. I have colleagues across the country who have been not supported in that way. And that makes it even harder to do the work, because you are sort of caught in this moral sort of dilemma, in this, moral injury state of wanting to provide care for patients who need the care, but then not getting the support to do that. And whether that's happening on a legislative level in the state that you live in, or on the hospital administration level in the program that you're a part of, it's, I think that's really untenable. So even though the attacks and the threats and all of those things have come, to know that we're in it together and to know that we're supported wholeheartedly by our hospital system and really by the community. I mean, the Twin Cities is a very welcoming community for LGBTQ folks. We have a great legislature in place here in the state. So from our governor, Tim Walz, to all of our representatives, they have really voiced support all along the way for the patients that we care for. And that makes a difference when it comes to community support and really feeling safe and supported to continue to provide the care that kids need.
Yeah, gosh, I am so sorry that happens to you and to your team and the hospital. And I'm very happy that you have the support and the resources you need to counteract it. It's an important resource. Oh gosh, thank you all. I'd love to sort of just go into some storytelling mode, and see if you can share a story or a memory about a patient or family who participated in your program that really sort of, it lives inside you. And so I thought I'd start with Aiden again.
Yeah, I have a story that I had in my back pocket when I first met you, Dr. Lown, and I want to share that again. We had a patient who I'll call Mike, who is a 40-year-old man who prior to the hospital was, I would describe him as being just so close to really getting started in his recovery. He was working in a kitchen as a cook in West Philly. However, living on the street. So he was in this very complicated scenario where he was doing his best to stay working. He was on a methadone clinic, dosing very irregularly because of his work schedule. So that led to his withdrawal being like somewhat managed by medication for opioid use disorder. And then he did supplement his needs with fentanyl when he would miss his methadone dose. So that's why I describe him as kind of being between treatment and substance use. What landed him on the street was that he has a wife that is actively in substance use herself. So he opted to essentially leave to focus on his own recovery and to avoid losing his job. He came into the hospital after a very tragic accident. He fell onto the train tracks, the L here in Philadelphia, which is a kind of shockingly common story here. Mike claims that he was pushed. I kind of suspect that that's not the case, but I don't think that's really of the point. The reason why that's a kind of common scenario here in Philly is that our patients are often buying substances in Kensington, which is right under the L train. And that's often a public space that is warm and safe when you're living on the street. He came in, was admitted to our ICU for after his back was injured and he had respiratory complications. So I had a lot of time to get to know him. I learned that he values his work so much. He had been working as a cook for about 10 years. He also was like uncertain about treatment. He was worried about going to rehab, thinking that that would make him lose his job. He was hesitant to restart methadone, even though that medication worked really well for him, because he struggled so much getting to that clinic regularly. When discussing treatment options for him, he was leaning towards trying to get back to work, which didn't sound realistic given his physical condition, and doing Suboxone, even though Suboxone is sure a very good medication for some, but Mike disclosed to us that he in the past had often sold his Suboxone medication because the temptation was very high to just get money for that medication that's prescribed to him. So this was back in early 2024. And luckily, this was right at the time when we were expanding our service through a philanthropic donation through the Scheller family here in Philadelphia. We opened our Bridge Clinic, which I know was kind of mentioned earlier in the discussion. That's our outpatient program. And due to the funding and partnerships with the city and other nonprofits, we now have a Jefferson partnered recovery house that has reserved beds just for our patients. So Mike was actually one of the first two patients. They sort of entered in at the same time. He went to rehab and then soon after went to our Jefferson partnered recovery house, where he was sort of off his feet, getting methadone treatment, and without any urgency to have to keep up his work. And now flash forward to October, he's about nearly 7 months abstinent from opiates and is working at a local deli chain that's actually right down the street from the hospital. Things I learned from this case is that there's a strong temptation for us to think of our patients as just being sort of typical. But Mike is really, struck me as a case that I'm so glad I learned about him and his idiosyncrasies and his needs and his complexities. What hid behind that strong need to work and stay employed was, I think, a sense of shame about his substance use. When we would talk about rehab, he would often be like, I don't want to use the city's resources. I don't want to be a freeloader. And I'm just so glad that us as a team are encouraged to work with patients in a long form way while they're admitted, and that we have the resources to build these very these wraparound services like recovery housing and an outpatient clinic and programs like that. So I hope that illustrates kind of a success story for JAMS.
Yeah, it does. And it also illustrates that, it's so easy to feel helpless and hopeless and unable to change, the trajectory of patients who have these really complicated problems, and yet it happens. So to really hold that up to the light, I think is really super helpful. Thanks, Aiden. Kate, do you want to share a story of yours?
Yeah, it is so hard to choose one story to share. The other thing that helps kind of weather the storms is the patients themselves. There is not a day that I'm in clinic with our gender health patients that I don't feel like this work is absolutely worth it. It's hard to say when you're putting your personal safety and the safety of my family, in some cases, at risk, but these patients and families deserve healthcare. And so here, being a part of their stories and seeing them light up, when I walk in the room, or hearing a family say, that appointment changed our life, there's nothing that can compete with that. I think I'm going to share a story with you about a teenage patient that I cared for. So this young man, when I met him, was about to turn 16. He lived in one of our suburbs here in Minnesota. For those of you who aren't familiar with Minnesota, we play a lot of hockey here. So there's a lot of hockey players here in Minnesota, including one of my own sons. But this young patient was a hockey player. At the time, he was one of the stars of his girls' hockey team, and really enjoyed playing on the hockey team, and had recently come out to his parents as transgender. And the dad was really not very understanding of his identity and what he was kind of going through. And the mom really had no frame of reference. They live in the suburbs here. It's somewhat of a homogenous community, and she had never really had any exposure to the LGBTQ community or trans people, but could see that her child was suffering and needed someone to talk to. And so she called our program and brought him in. And what I distinctly remember from the first appointment, it was the mom and the teenager. And when I walked in the room, he was kind of barely holding it together. He was kind of on the verge of tears, sort of talking and answering questions. The mom was very pleasant, very much was open that she didn't really understand what was going on with her child, but, wanted to learn more and be there to support him. And when I got him alone and we started talking about kind of what was going on at home and interactions with his dad, he's just broke down in tears and just was very upset about really kind of hating himself and hating that he had figured this out about himself, but also knowing that that it was who he was, and he didn't want to stop playing hockey and had such a family with his team. And I continued to see him over the next 4 or 5 years. And at first when they came in, mom really said, we don't want any medical treatment. We just want support for our child. And so we kind of met them where we were at and helped him access some support resources. We were able to start birth control medication, essentially to stop his periods, which were causing some distress around his gender identity. And, as time progressed and mom learned more and dad started to soften a little bit, we have a gender health program therapist that does family therapy with families to kind of help them talk through what issues might be going on there. Because as many of you who might be in pediatrics know, pediatrics is as much about working with parents as it is about working with kids and teenagers themselves. And what really struck me about this young man's story is that I eventually ended up transferring his care to one of my partners, and he started on testosterone sort of toward the end of his high school career. And I saw him back on my schedule one day, and he was there for a testosterone follow-up. And at this point, he was 19 years old. And I walked into the room and I almost walked back out. I could not believe that this was the same kid that I had met, 3 years earlier, sitting there smiling back at me. There was this young, confident, early college student just smiling and happy and, just bounded up on the exam table and was so excited to tell me about college and how it was going in his classes and everything he was involved in. And the sense of self and sort of self-confidence that I saw in this young person before me was just night and day from, the teenager that I had met who was scared and sad and just, didn't even know that, there was a future for him and what that might entail, 3 years earlier. And so, it's stories like that help us know and help me know that, this is the right work and that, this is what patients and families need, because every kid deserves to thrive like that. And to see this kid thriving and just living his best life and, being his best self is just one of the greatest gifts of, being in medicine at all. Seeing our patients do well is such a rewarding thing to experience.
That's wonderful. Thank you so much. Thank you for both of these beautiful stories. I wonder if we could sort of switch gears a bit and talk some more about thinking about, we always keep having to sort of prove our worth, even though we know it's it's important. But how have you measured success? How have you defined what metrics might be available to you to sort of, I think, just document that these programs are important? I mean, I think for some, they want to know that their investment in these programs is something that's proving to have positive outcomes, and I'm curious about that. So I'm just wondering how you might have measured the success of your program. Phil, do you want to take that one first?
Yeah, sure. So we've looked at several different metrics. I think the best way for me to kind of describe our approach is really starting at the front door. So we put a screening mechanism in place in the emergency department of just a brief questionnaire. And the data that we've shown from that is we've screened since JAM started and its conception, we've screened about 30,000 individuals that have screened positive for substance use disorder. A lot of them who didn't even have that kind of on the radar were coming into the hospital for completely unrelated medical complication. That's about 10 times the national average of patients that identify in the inpatient setting for having substance use disorder. And so far, we've treated about 2,300 of those patients with our withdrawal protocols. We have pretty novel withdrawal protocols with different medications to try to combat not just the acute opioid withdrawal, but also there's no evidence-based guidelines so far for xylazine or tranq withdrawal. It works on a completely different receptor in the nervous system. So those numbers are really reassuring. We have also looked at a reduction in readmissions for our patients that have opioid use disorder from about 16% to around 11%, which is definitely trending in the right direction. And then I think the last metric that we focus our services on is definitely looking at patient-directed discharge, which is the same as against medical advice. So our patients are obviously high utilizers of inpatient care. They frequently come into the hospital, and a large majority of them will leave within 24 hours, if they even make it to that point, because their withdrawal is just so severe. So they can't even, think about or hemodynamically speaking, stay in a hospital if their withdrawal is not controlled to get antibiotics or wound care or, whatever reason that they presented to the hospital for. So hot off the press for the last academic year, we ran data for improving patient-directed discharge, and we took that from 40% to 22% for the last academic year. So that's really exciting. Obviously, Beth, like you mentioned, we have to highlight our services and what value we can bring. We know the value, obviously, of the patients we work with and the stories and the impact that we have. But for a system at large, I think now that we've declared that we're a specialty and we're a service here and we're this unique co-management service, looking at these numbers has been very promising for our program.
Oh, that's fantastic. Congratulations. That's really impressive, actually.
Thank you.
Yeah. Thanks, Phil. Kate, you want to talk about that on your end too?
Sure. It's interesting in the field of pediatric and adolescent gender health to think about how you would measure success, because there's not one treatment outcome. Every young person that comes through the door is going to have different goals, and so they're all going to either get treatment, not get treatment, get some treatment and not others. Everyone has an individualized care plan, and so it's all a little bit hard to track in terms of that. So what we've really focused on is a few things. We're measuring success in terms of how many patients we're able to get through our doors. We know that there's a huge demand for services, and so the more patients that we can see, the more we know we're serving the community. We do patient experience surveys. It's a little bit tricky there because the way our hospital does them is there's a text or a go to the house component, which in terms of some of our patients, we're really sensitive to confidentiality and different parent relationships. And so those all happen actually by hand in clinic when we do those. And so we've done some of that. And what we're looking on doing right now is building a REDCap database to try to for lack of a better word, track thriving. And so the way that we can do that is to really see how folks' mental health is improving. So we do monitor sort of point in time mental health screening every visit using the PHQ and the GAD. And then we also have a mechanism in our database to track inpatient hospitalizations and or emergency department visits for mental health reasons. And so we're hoping to see those trend down over time for our patients. And what we know about our program is that our year over year sort of number of new patients going in continues to go up. We know that 92% of our patients who we see in any given year will come back to see us the next year. So we have a really high retention rate for patients, which I think is a signal that we're meeting patients and families' needs. And then we've really, when people ask me what trans kids need, I know what they need more than anything is culture change. And so what we have really tried to do is implement really hard, solid changes in our healthcare system to make the healthcare experience more inclusive for patients, no matter where they walk in, whether that's our gender health program, our emergency department, our primary care clinics, wherever they go in, they're having a good experience. So we're undergoing huge changes in our electronic medical record to be able to track pronouns and chosen name. We have added the option for pronouns to all of our employee name badges. We have elevated our health system to receiving the Human Rights Campaign Health Equity Index leader designation for the last 4 years, which is a perfect score of 100 on their equity index when it comes to LGBTQ inclusiveness. So we're really doing everything we can to measure our health system to make sure that we're the most inclusive possible. And then we're trying to make our state the best state for kids to get care. And so the legislative advocacy that we've been able to participate in 2023, we banned conversion therapy in the state of Minnesota, and we passed the Trans Refuge Bill, which protects access to essential health care for young people in the state of Minnesota. And our team was involved in giving testimony and speaking at press conferences and really helping to get that in place. So part of our measure of success too is what impact are we able to have on the community as a whole. We've worked with our local school systems to incorporate gender inclusive policies. I've testified at school board meetings and things like that. So really helping our kids and our families beyond the walls of just the exam room to make sure that they have what they need to thrive.
You have quite a dashboard there. I mean, you're helping on the individual level, at the organizational level, re-educating and educating and re-educating, trying to change culture within the organization, and also, at the state level. So, again, congratulations. It's such hard work. And I'm hearing how rewarding it can be and also how challenging and stressful it can be. Amazing. Really respect what all of you are doing. I just want to remind people in the audience, if you'd like to ask any questions, just pop them into the Q&A pane, and we'll try and get to those, towards the end of the session. I'm curious, it sounds like you've all forged a path into the future, and I hear that, there's so many threads to what you've said, Kate, about, gathering your support at all different levels. Is there anything else you would want to add to that in terms of how you plan to sustain your work, especially, given the political tides and goodness knows what's going to come down, the pike this year, next year?
Yeah, I mean, I think really our focus continues to be on access and making sure that we have enough team members and enough services in place to meet the patients and families' needs. So I think that's probably our biggest focus over the next 1 to 3 years, is really making sure that we can do that. And then, this position that we've been put in is sort of this island state that provides care to now, several surrounding states, really making sure that we're a center of excellence for that care. Like, I don't think it's good enough for kids to just get care. I want them to get the best care possible. And I want to be a model for what that really good care can look like, because I would love to help other people across the country who are in states like Minnesota that have shield laws, or other places, be able to provide really good, high quality care. And of course, we'll continue to advocate for our patients in our community, not just here in Minnesota, but across the country, to make sure that all kids have what they need. No kid should have to travel out of state to meet their basic healthcare needs. And, this is not one-time care. This is essential care that happens over multiple visits over multiple years. And so it's a real hardship on a family to not be able to get that close to home. So I think continuing to work to make sure that this is essential healthcare that all kids can get at home where they need it.
That's fantastic. Thanks, Kate. Phil, how about you? You also spread your program into an adjacent hospital. You want to talk about that, and also your ideas in general about sustaining your work into the future?
Yeah, it's so fascinating to hear the parallels of
Yeah.
our programs. I mean, they're endless. It's just so interesting because we're situated in totally different patient populations and areas of the country. So I'm just like my wheels are spinning about how fascinating this is between our two programs. But to echo a lot of what was already said, I do think, resources and access are, again, really hitting the nail on the head. We just expanded to Methodist Hospital, which is a smaller community-based hospital that's in South Philly. Because of our patients really, ending up in different hospitals and emergency departments around the city and amongst the Jefferson network. We are, always being approached to expand our services, which is a good thing, because there's such a need to continue to grow our team and to have access to, an addiction medicine specialist. I do think other like sustainability options in the future are also aligned with just addiction medicine growing as a field. It's definitely more novel as a specialty service and as a you know just as a degree in general. It's an ACGME recognized program now. So I do think curriculum development is really important. We've been approached here with opportunities for both UME and GME programs and initiatives starting in the medical school. So I do think like continuing to work with these metrics and showing how successful our team can be will continue to allow us to sustain and grow our program in the future. But going to a hospital in a more conservative area of the city is definitely aligned with a lot of culture change. I think a lot of people look at substance use not as a medical diagnosis. They look at it as either a psychiatric illness or, a willpower issue. So a lot of our team is not just providing, again, medical recommendations for patients. We're really trying to work with the infrastructures in these other hospital systems to provide support for all members of the care team. Working with this patient population can be challenging, and I think it's a large source of burnout and issues with retention of staff. So we've also had discussions kind of along those avenues as well. So
That's helpful. Thank you. You all need Schwartz rounds and stress first aid programs. Just saying.
We have Schwartz rounds.
Yeah, that you do. Okay, thank you so much. I think the last question, there's a couple of questions in the Q&A, but last question I would have is, what do you want people to know? What advice would you give, if you can sort of think about it that way, to people who might want to start a similar program in their organization or in their community? What would you tell them? So, Kate, why don't you start with this one?
Yeah, I would say two things. I think you need to understand what your message is going to be and who your audience is when you're trying to give it. So I knew walking into the operations team that yes, I was going to talk about budget. Yes, I was going to talk about need. Yes, I was going to talk about patients. But what I was really going to talk about was equity and commitment to equity that our health system had leaned into, because I knew that would be a message that they would listen to. So I think you always have to speak the language of the people who you want to listen. And so you have to find the right language to make the case for the care that you're trying to provide. And then the other thing I would say is it really takes a strong foundation. I had a coalition of people within my health system who respected me as a leader, who trusted that if I felt this was an important direction for a hospital to go in, that it was an important direction. And so I think you have to sort of build that kind of coalition, or I always think of it as like, who's on my board of directors? Like, who will speak for me when I'm not in the room? When the gender health program comes up, who's going to be there to say this program is too important and we can't let it slide. We've made a commitment to this community, because I might not be in that room, but I need to know who will be in the room to say those things when I'm not there. And so I think having that like strong coalition and kind of foundation of people supporting your work is really important. And then making sure you have messaging that will really resonate when you're trying to make the case for the care you're trying to provide.
That's really important too, the messaging and the communications. So really having a strong leader, a team, a coalition and champions who will be ambassadors for you, plus all the resources that you will need and leadership support. Thanks, Kate. Phil, what about you and Aiden too, if you want to jump in on this one? What advice would you give to people who
Yeah,
want to start
I
something?
within our community, I would share, we're dealing with a lot of political change locally as well. We have a new mayor that is really attacking a lot of harm reduction efforts in the city. But I also think it would be senseless to lose harm reduction principles within a hospital setting. To expect our treatment to be the cure for a substance use disorder would be ridiculous. So just to answer this briefly, I would say, be guided by harm reduction strategies and principles, while still, obviously leaving open opportunities for patients to, set goals for full abstinence and sobriety, while still, that shouldn't be the be all end all of success, which kind of goes back to our last question.
Yeah. Save lives first.
Yeah.
I
Phil,
think
how about you?
Yeah, I think kind of just building on what was said already is finding, like-minded, motivated people. That's really how the conception of JAMS started. It was, different faculty and different department that just realized, we need to come together. We can do better. We can serve our patients, this patient population, in a much more cohesive way. And that really generated a lot of momentum. And then I think another lesson that I learned is, it can be really hard to, boil the ocean. So defining success and milestones of this is how the program's going to start. This is realistic. This is what I can do today, this week, this month, this year is really important so that you don't lose steam and momentum. And I think that's really how our team has come together and has been, so successful.
That's really helpful. I mean, a strategic plan, so you actually have the milestones and the benchmarks and a timeline, so you really don't feel overwhelmed by having to do everything all at once. Super helpful. Let me just field some questions over to you. There's a question here about building. What approaches have you found effective in building trust with patients who may have had negative experiences with the healthcare system? This is really critical. Yeah, Aiden, you want to go for that?
Yeah, that's a really, really good question. Patients with opioid use disorder in particular are heavily stigmatized within the hospital setting, and that's well documented and researched. One brief thing I'll mention is it's really about the patient encounter, using your personality and the art of the interview to build that initial trust, and then really just in practice prove it to them that you're willing to be on their side and be delicate and caring. And we see that a lot with patients who are one small example of this is patients are very afraid to try Suboxone as a medication for opioid use disorder because their experience with that medication is it puts them in precipitated withdrawal. We have to very delicately encourage them to consider, that we have our own method of giving patients small dose inductions on that medication, and they often don't believe us, and they're very worried that we're going to put them into withdrawal. But it's like I said, the art of the interview that lets them kind of opens their mind to that.
Phil.
I think harnessing the shared agenda between the provider and the patient is really important. I think I've had to check myself multiple times when I hear about a patient before I enter the room, thinking of what my agenda is versus what the patient's agenda is. And sometimes things are really simple and they'll tell you what they're looking for. And I think defining success is not trying to cure substance use disorder in every single patient we see. Defining success might be having the patient feel comfortable working with a nurse for the first time, or having a patient get a dose or 1 or 2 doses of antibiotics. So I think it's really important to not push, like for us, every single patient does not need to be on Suboxone and methadone for us to feel successful or for us to feel like we've had an impact.
That's incredibly helpful. Kate, one very brief answer from you, and then I was so sorry, we're gonna have to
Yeah,
close.
no, I really like the shared agenda setting that Phil said. We're in the unique position where we're trying to build trust with both the adolescent and the parents, often who are maybe coming from different perspectives. So I think uniting around a similar goal, I want what's best for your young adult, they want what's best for them, and I know you do too, and we'll figure out together how we're going to get there is a good way to do that.
And partnering, collaboration, and reciprocity. Thank you all so much. It's been it's really been inspiring, and especially, you know, when it feels so hard to make important change in the world and the forces seem so daunting, you know, as they pile up. It's just really inspiring to see what you've been able to accomplish. So these are well-deserved honors, and I really hope that others will take to heart all the wisdom that you've shared today. Thank you for sharing that and for sharing your stories as well. I'm going to turn this over to Julie right now so we can close out.
Great, thank you. Thanks so much to our panelists and to all of you who joined us here today. We hope you enjoyed this Compassion in Action webinar. Please keep an eye on your email for news of future events. And finally, please take a moment to fill out the very brief survey we'll be sending you after the webinar. We appreciate your feedback on today's session. Thank you for joining us and for your commitment to compassionate healthcare. Take care and hope to see you soon.
Goodbye, everybody. Thank you.